All right, let's talk patellofemoral dislocation. So this is where we just talked about the patellofemoral joint, where it is in the trochlear groove. And so there are two reasons that would cause this to dislocate. And I just want to be clear that when we say patellofemoral dislocation, this is just the patella coming out of this trochlear groove. When a lot of people say they dislocated their knee, they're referring to this. But a true knee dislocation is tibiofemoral, where you have to have 3 or more of these main ligaments torn so that the femur and the tibia are not articulating. And that's a limb-threatening injury because there's an artery that can be cut off. And it's very, very serious. So we're not talking about that. We're talking about this superficial joint here that is very mild. There's no vessels, there's no arteries that we have to worry about. So why does this happen? Well, usually you can't just have a force, and that's usually like an isolated time where it happened because someone was hit on the medial side and pushed it laterally and it slid out and it was like a freak thing. And if that happens, then that usually doesn't happen again unless there was a secondary injury. And the most common secondary injuries that happen are MPFL tear. You have a ligament that attaches to the medial side of your patella and attaches right here to the medial femoral condyle. And it's called your MPFL, medial patellofemoral ligament. And so when someone dislocates, the first thing I teach people is to palpate here and palpate here and see if there's an increase in tenderness, especially something that remains a day out, because that usually means the patellofemoral, the medial patellofemoral ligament was torn, and that has to be reconstructed, or you're going to have a lot of instability because you naturally have all these lateral muscles on the outside with the IT band, the vastus lateralis, and that retinaculum that is just providing a lot of stability on the outside. So it's imbalanced when you don't have that MPFL intact. The second thing is that when this glides out, this cartilage, so this bone is lined with cartilage, and so that can easily tear off. If you were a young athlete or an adolescent, then your bone is spongy because it's still growing and it's more likely to pull off. So in that 9th grade boy, that's where I saw a lot of these medial femoral condyle defects where the bone just pulls off. This can happen for a variety of reasons, but it can be related to this as well, to this dislocation. So if there is bone defect, so a piece of bone or cartilage, a chondral defect is what we call the piece of cartilage on the bone is pulled off. It's in the joint. That means this isn't going to glide smoothly. You now have something blocking it and causing instability, and it will dislocate again. So if you've dislocated once, you're actually 50% more likely to dislocate again. And that is because you either have some kind of inherent thing about your anatomy that we'll talk about in a minute that's making you dislocate, or you have this acute injury and you now have an injury that's going to make you more susceptible, like an MPFL tear or a defect, a chondral defect. So now let's say it wasn't an acute thing, it just happened spontaneously while you were running. That's also this valgus collapse thing that we've talked about with every other injury in the knee. But the reason why the patella would pop out is because you have a really shallow groove. This is congenital. This is you're born with it. There's nothing you could have done about it. And it's really hard to intervene. So doctors can go in and curve out this groove to make it deeper. It's really hard to do, and the outcomes aren't great. You would want someone who does this all of the time, which is going to be a really big specialist. It's hard to get into. You want that guy carving into your groove. And so that the only time you would ever do that, because it's a really painful surgery and the outcomes aren't great, is if you're having lots of dislocations. So the time that I have seen that in the clinic was a 13-year-old that had like over 20 dislocations, and it was basically super flat. And so that would make someone dislocate if they have a shallow groove and this patella is just basically sitting very superficially and can shift out all of the time. That is the candidate for a brace. So if someone didn't want to get surgery, or they just want something until they get surgery, having a brace that provides, it's basically a neoprene slip-on brace that has some kind of medial support that basically or a lateral like bridge here that will basically prevent it, for like a ridge that will prevent it from going over it. Sometimes people will use that. Otherwise, we try to avoid braces so that we're not inhibiting our neuromuscular feedback that's happening. So at the end of the day, dislocation, know that it can happen acutely, and it can happen just like running non-contact without any direct force from that valgus kind of motion, but usually because you have a shallow groove in there or you have some kind of instability of like a defect. And then when you have an injury to it, you need to rule out that there's not a chondral defect that's causing instability in there, and that the NPFL is in fact intact, because those things will make you much more likely to have another dislocation. If you have any questions,